Hi, good afternoon, everyone, and welcome to the World Heart Federation Heart Cafe. My name's Jeremiah Mwangi, and I'm the Director of Policy and Advocacy at the World Heart Federation. And the session that we have this afternoon, and we're joined by two excellent speakers with a lot of experience, is on tackling tobacco and tobacco control, and what the role of cardiology societies, heart foundations, and cardiologists is in that fight against tobacco. So we'll hear some stories, some experiences from my panelist on the far side, who's David Lloyd. He's the CEO of the National Heart Foundation of Australia, and he will share with us some of his learnings and experience in the fight against tobacco in Australia. And then also I have a fellow panelist is Dr. Noreen Nazir. She's a cardiologist, and she's the chair of the, and let me get this right, Smoking Cessation and Prevention Work Group of the American College of Cardiology. And so I think with that, just to set the scene, I think it's really important that we remember that tobacco is one of the leading risk factors for not just cardiovascular disease, but NCDs as a whole. It's an issue that has been facing us for some time. There have been a lot of activity on it for the several decades. We've seen successes and we've seen failures. And I think one of the challenges that we face today is that with the tobacco industry, with the new and innovative products that they're bringing to the market, and the language that we have of tobacco control, one of the things is we're thinking, how do we broaden that language, because we're moving beyond tobacco, looking at products that deliver nicotine, e-cigarettes, and so forth. So how do we keep the narrative alive about the need to combat this risk factor for cardiovascular disease? And how do we engage more people? I don't know if any of you have been to the earlier heart cafes today, but they were very full in comparison to this one. And I think that's a shame, because this is still such an issue that's so critical and important for cardiovascular disease and achieving our global goals in cardiovascular health for all. And so with that, I'd like to turn to my panelists, and we'll have a bit of discussion here, but also we'd love to hear from you. Any questions that you may have or insights and experiences related to tobacco control. So Noreen, one of the first questions that springs to mind is really, what is the role that cardiologists can play in tobacco control?
Thank you so much, and thank you so much for hosting us to discuss this topic. I really appreciate it. So I think just the premise of this being here shows that we really need to emphasize the importance of this. We can already see that we're in this very large exhibit hall, and we've got just a few people at our discussion, when this is a known traditional risk factor for heart disease since the 1950s. Now you can go and you can find so much information on hypertension, so much information on cholesterol management, and all cardiac disease risk factors, but really, this is what we've got for smoking when it is that known traditional risk factor. So I think one is informing people, getting the word out, very importantly, but then who are we getting the word out to? So cardiologists need to be primary in working with people on how to stop smoking and how to prevent it, actually. When I first got involved with the work group, our title was Tobacco Control Work Group, and I changed it to Smoking Cessation and Prevention, because it's not just stopping people from smoking, it's preventing them from starting to smoke. So how do people get prevention from smoking? Knowing the importance and how much it affects your heart health can be a huge deterrent. So I think that really helps to say a cardiologist should be engaged in doing that. A cardiologist needs to be in the forefront. And I think what happens a lot, and actually we just did a survey with the support of the ACC through our Prevention Council on figuring out what are resources that we need to talk to people about how to quit smoking at their most vulnerable time, which is that in-hospital first event time. And that survey came, and it said 1 out of 10 cardiologists actually we had a very high percent, everybody wants to talk about it, but only 1 out of 10 felt that they were comfortable in talking to the patient about it, and they felt that primary care, ancillary staff, or another subspecialty would be the ones to talk about smoking cessation, smoking prevention. So, we really need to kind of embrace that this is a problem for cardiovascular disease that's been well known, But then we also need to say, well, if it's a problem for cardiovascular disease, you as a cardiologist, you as a cardiac care provider, be it, support staff, whatnot, should also be willing to at least bring up the point, the association, which then hopefully can help with prevention, but then the correlatory that if you are smoking, you need to work on cessation. So that's where I think it's at the initial visit, that in-hospital visit, and all throughout.
Thank you. And how, in that role of supporting patients to stop smoking, how can we support cardiologists to feel more comfortable in taking on the task that you just mentioned? Is it a matter of training? Is it the way that the funding is working in terms of the time commitment that's there? Is it more institutional? How do we kind of support that work?
I think that's a great question because it brings in so many of those aspects that we looked into in that survey. So that survey project actually came up from an idea that our work group actually, just going back, our work group is the smallest work group out of all the prevention section work groups. So I've got just a core group of cardiologists, and one of my senior colleagues had said, I have this great smoking cessation kind of tobacco control group staff at my hospital, the hospital that he was working at. And I was talking to him, and he's like, we should make a program, we should roll out a program on how to educate people on smoking, similar to this. And I brought to him, I said, your hospital is very different from my hospital. You are at more of a kind of like enclosed health system. I work at a very large urban medical center and an academic medical center. Our resources are very different. So before we implement what you're doing at my hospital, why don't we get a good understanding of what we need? So that survey helped with that. But one of the second parts of the survey is like, how do we educate? How do we fix this problem? So there were 3 things that came out. People want continued medical education. This is from the ACC. They felt that we need more education on how to do this. And what the education was, both behavioral therapies and both information on pharmacologic therapies. So what do we do from a cessation standpoint from those? And the CME was thought, you can send us out as webinars, you can send us out and like click and play at your leisure, but really we need more education. We need more ways to be informed on how to do this. There were components in there that individuals also said that it would be great to have a formal smoking cessation program at my institution, in my hospital, but going into it, it varied amongst the size of the hospital and the support that the hospital had, but really everybody did say we do need more education on how to do this.
Thanks. And continuing on cessation and the tools that we have, I mean, one of the things that we're seeing raised are that the newer tobacco and nicotine products, such as e-cigarettes and heated tobacco products, are often advertised as cessation tools. And so from your perspective as a cardiologist, are there potential dangers of that? What do you think how should we kind of build a narrative around the use of these new products?
Yeah, I think how these products get in the market and whatnot is because they have not had that time to show all the data that we've had from the 1950s, 1960s. It still took up till the 1980s to 1990s to actually get smoking to downtrend, meaning that combustible tobacco. This is that non-combustible nicotine products that we're talking about. It's just time hasn't passed to demonstrate what will be effects that we do not want to see in the patient population. So I think we should try to somehow use that experience that we've had from smoking to put on this, but of course, there's a lot of other factors working against because they've got maybe stronger marketing, which we know in certain vulnerable populations, they're really heavily marketing in this. And also, the regulation for this has been a little slower. The products are out, the regulation is coming out much slower. So unfortunately, we're at a place where time is kind of not helping out. But yeah, I absolutely think their answer always is, we don't have enough data. Well, the reason we don't have enough data is just time hasn't passed, but data will come out, and it's not going to be the way we want it to, for patients to think that this is something they should use.
And you were one of the co-authors of the WHF policy brief on nicotine and cardiovascular disease. Just how bad is nicotine for the heart?
Yeah, so I think it's been well known, but there's there's many acute effects, and then there's many long-term effects. So acute effects, your heart races, your blood pressure rises, sometimes you get short of breath, whatnot, just from that. But long-term effects, it's actually causing damage to your vasculature, to your arteries, where you're going to then be at higher risk for inflammation, which that inflammation just directly after a series of processes just leads to myocardial disease, which is myocardial infarction, so heart attack. So acutely, you're going to have some problems, and then over time, these problems lead to having myocardial infarction.
Thank you. I'd like to turn to David, and reflecting on a report that came out from WHO last year that while prevalence of tobacco use is falling, absolute numbers of smokers in the world is actually increasing due to population dynamics in countries where smoking rates are high. Australia has been a global leader in tobacco control, from plain packaging to strong taxation policies. So what lessons can we learn from the experience of Australia that can be shared with other countries who want to bring down their rates of smoking?
Well, thanks, Jeremiah, and Noreen, thanks for your comments there. I think it's fascinating to consider that point that you made, that nobody has vaped for 40 years yet, so we don't actually know. But the transfers, to pick up your point, Jeremiah, the number of people who vape in Australia who then become smokers, we reckon at the moment is about 10 times the number of people who are smokers who use vaping to give up. So the direction of traffic is really, really clear. And we don't, I think, need to go back to the 1960s and work the whole thing through again so that we do the whole smoking cessation program again. We can fast track it this time with vaping because we know the language of big tobacco. We know what they're doing. And we can see the end game quite quickly, I think, now. We don't need to ask ourselves all the same questions. To your question about what's worked in Australia, I'm always very nervous about translating the experience of one country to another. Australia is a particular place. We have an enormous landmass. There, one of the issues we have with the illicit tobacco trade in Australia is that it's very easy to land on the Australian coast and bring illicit products in. It's a very, very hard place to regulate. We have a federation. Like many federations, it works quite well, but not brilliantly. And as we've been bringing new legislation in Australia, particularly to deal with the next generation of smoking and with vaping, we found that it's relatively easy, if you've got political leadership, to get things done at the federal level, but then implementation happens at the state level. State governments have different priorities and different cadences, I suppose, of decision making. I think in Australia, probably the biggest lesson that we have that is translatable to other jurisdictions is that you need very, very long-term political leadership that absolutely ties their name to it. Now, excuse me, in Australia, leading up to 2011, when we introduced our plain packaging regime, which is one of the things that really did reduce smoking rates massively, we had a health minister at the time who literally made this her big thing. She focused on it for pretty much her entire tenure, and it became a famous legacy to a point that 10 years after plain packaging was introduced in Australia, there was a regathering of the good and the great in Parliament House who had been involved in that, getting the band back together after 10 years to congratulate ourselves for it. That political leadership was very necessary because it got very nasty. I mean, big tobacco is not nice to political leaders who stick their necks out as far as Nicola Roxon did. The other thing I think we learned during that time was to go for the whole supply chain. You've really got to go for. Now, I mean, you introduced in your introduction, you talked about the new and innovative products. You'd not be allowed to say that in Australia because you're not allowed to use language that is in any way interpretable as positive about nicotine products. So I think going going for the language, going for the environment in which people make decisions about what to buy. Obviously using tax, but I think, to be honest, we've used tax as much as we can. We've actually created 20% of our tobacco market in Australia is illicit trade, and I think we've kind of created that in a way with our tax system. Border control for illicit drugs, youth influences, that kind of thing. And finally, what I'd say, and I think Nicola Roxon really showed us this, is we need to be as cynical and as ruthless as the industry itself. We're all in health, and we tend to play nice. And this is a nasty industry that we have to be very, very direct and overt in confronting. And that's it's hard in a democracy like Australia, America, Canada, whatever, but you've got to really be prepared to put your political name to it. And we've been lucky in Australia because we've had a series of health ministers that have been prepared to do that, and a current health minister who has basically done the same with an updating of our tobacco regime, but also really tackling the vaping pandemic very directly.
Thanks. And there's an election coming up in Australia, and I'm going slightly off the
No, don't worry. I can always talk about an election in Australia.
And just out of curiosity, is the Heart Foundation making some calls related to the current tobacco control regime? Yeah. Are there some things that you'd like to see in the pledges of all the parties that are running?
Yes, I think actually the federal government has done as much as it can. The rest of the job really now relies on the states and territories, where they have to implement the regime that has been created at the federal level. For example, largely speaking, what's happened in Australia is that you can only now get vapes over 20 milligrams, I think it is, through a pharmacy. You're not allowed to have, whether it contains nicotine or not, and that's an important statement, because many that do actually say they don't, or at least don't indicate. You're not allowed to have flavors. Menthol cigarettes are about to be completely outlawed. The health minister, he told me recently he wants to have every cigarette a dirty brown color rather than white, and he wants to have the health warning along the side of the cigarette. Now, that's literally where we're going. You already look like a fool smoking, but you're going to look like a real fool smoking one of these. But to the Australian political system, if anybody's interested in this, we have a proportional representation system, which means that in the Senate, our upper house of review, we always end up with a few minor parties who quite often, and certainly after the next election, which will be very tight, will hold the balance of power for legislation going through our government, through our Senate. And they are variously crazies, because they can get into the Senate with very, very small direct numbers of votes. And often, and I've been in conversations with this, and this is something we have to do, each of these members of the Senate one by one, and quite often they've got an N=1 story of their own about how somebody smoked until they were 90 and lived a long, happy life, or somebody, their uncle, there was one who's got 3 seats in the Senate actually, and their health spokesperson told me they were definitely not going to support the government's vaping legislation because her husband had given up smoking using vapes. N=1, but it was actually going to it produced the risk of the national legislation changing. So that's a very important thing for the Heart Foundation, is getting behind the government when it's doing something really quite brave like this, getting the major parties on side, which isn't that hard. They do it for different reasons, but it's not that hard. But then sweeping up the very, very minor parties in the Senate and making sure that it doesn't fall at the last hurdle. Politically, that's very important, and it has traditionally been a very important role for the Heart Foundation.
And you talked about the need to be aggressive in the way we combat the tobacco industry. What does that look like?
What does that look like? Well, there haven't been donations to political parties from the tobacco industry in Australia in 2011, apart from one, which I'll say the National Party has had donations from industry associated with tobacco up until last year. We won't shy away from pointing that out. I think shining a light on the language tactics is also very important. When the IQOS and other e-cigarette products started coming out, there was a subtle but very clear change in the language around them, which is quite insidious. And it's really important that when people are talking about aerosol, for example, rather than smoke, sticks rather than cigarettes, you've really got to go in there and make sure that the language changes, which are very, very, very cynically being used, are highlighted and brought to that. We, as obviously as any Heart Foundation does, we have a pretty large number of eyeballs on us, and we can point that language change out. It's a useful contribution I think we can make, and then we have to find common language between the political parties. I mean, there is quite a bit of, on the right in Australia, there is quite a bit of people choose their own poison and everybody has a right to kill themselves their own way kind of thing. We have to make sure that we draw that language in towards what they would call the nanny state language of the left, and we have to make sure that there is a common national language, because you can only get a national consensus on this if you find a language that all sides of politics can use. And that's another contribution we try to make.
Thanks, David. I'd like to open up to the audience for any questions. We had a perspective from cardiologists, from the Heart Foundations. And just while you're thinking about your questions, I'll come back to you, Noreen. We were talking earlier that the tobacco expert group at the World Heart Federation had developed a joint editorial with the Air Pollution and Climate Change expert group. And just thinking about how those two issues are related, what motivated having a joint publication with that group, and what kind of things were you putting an emphasis on and stressing?
Yeah, thank you. So fortunately, we're very kindly able to coordinate with our colleagues at the Air Pollution Expert Group. This document actually focused on not the pollution from what happens when you produce tobacco, when you produce the plastic and all those. I mean, that's a very large topic. This was actually on the pollution coming from side stream smoke, secondhand smoke, and third-hand smoke. So looking at, meaning actually just the smoking of this cigarette product, or the combustible products, I guess we can say, because there's many other ones. And just looking at the environmental impact from that, then how it's affecting the air and whatnot. So fortunately, we came up with a really nice document, because there is so much that it is contributing to in air pollution. Certain regions of the world, especially low and middle income countries, because of those regions already have a higher use of combustible tobacco products. On top of it, already a air pollution level that is above what the World Health Organization recommends for air quality. So it's almost like a compounding factor. So we were able to highlight things like that. We were able to highlight just how they're almost complementary. You're going to have one, you'll likely have the other one. And also, the last part of the document is kind of to highlight that, we need to, it's a contributor. Everybody is very interested in air quality, air pollution, kind of climate change. Well, this is a large contributor to that. Make sure it's included in all those discussions as well.
Thank you. Are there any questions from the audience, or if you are working in tobacco control or in supporting patients with quitting smoking, if you want to share any of your challenges or success stories, we'd like to hear from them. Just opening it up to the group. Please.
Hi, I'm Jess. I'm a third-year internal medicine resident. I have a question for you, Dr. Nazir.
Sorry, could you...
yes.
Thanks.
I have a question for you, Dr. Nazir. When it comes to a conversation and you're trying to counsel a patient in this, prevention mindset of smoking and not wanting to start in the first place, what would that conversation entail? What has been successful in your experience?
First of all, this is fantastic to have somebody at your level in training here. So congrats. Thanks so much. Make sure you tell all your friends to come too, because really, it actually starts so early. And that, I mean, I think we need to do a survey in medical schools. What is the educational component being told in medical schools, right? We all learn the effects, negative effects, but then where is the component that we're learning about what should we tell people? You know, I mean, we have all those types of conversations, how to have this type of conversation, how to have that type of conversation, but I think sometimes we get to this point. But then now going directly to your question, so I think it helps when your clinic or your staff, and I've, been able to foster this, ask patients, right, do you smoke? So they already know, okay, somebody's going to ask me this, so like, in the intake staff, somebody's already asked you. And there's a lot of studies, or I guess, studies that have shown that if you include smoking as a vital sign, like the intake, you actually increase the discussion of that in the physician-patient conversation. So helping yourself set up for success, try to see if the medical assistant, the intake staff can already put it in. There's also studies that have shown that when it's built into the electronic health record, that you have to check off something, that also increases the discussion of smoking. Because if you leave it without either of these, the percentage of people who mention or who engage from the latest, and actually we just had a publication in JACC Advances that touched on a little bit about this, but it's in the sub 25%. So, and over 70% of smokers will see a clinician within 1 year. So we're missing such a large population. So doing things to help you kind of set up for success, so getting that intake to help out, or getting that electronic health record to help out. But of course, us as clinicians, just always thinking about it. Like I touched a little bit, sometimes people think, oh, they're going to have it talked at primary care, or they'll have it talked about there. I think you know it, you see it, you should at least make that mention, because there's of course data. Anytime, the more times you mention it, the better chance you have somebody to at least change. So I always ask, and then I always say directly, like within the time they tell me that, not at the end of the visit, just directly, like I strongly recommend that you quit smoking. What resources can I provide you? And, when they're like, oh, I know, and I'm doing okay, and I'm working on it, fine, but I always say, I'll put in patient instructions resources, but if they say, okay, what resources can you provide? So then I stop my visit and tell them at that time, and then we'll move on to the next things and whatnot. But really, anytime, all the time, to help out with this huge preventable risk factor should be the way to think about it.
Thanks. Any other questions? I had a follow-up, which is the World Health Organization recently brought together a consortium on tobacco cessation, and it included the private sector, NGOs, medical community, and some of the private sector we had around the table, Microsoft, Google, Johnson & Johnson. So looking at different things like nicotine patches, drug therapies, patient tools for the online tools, digital tools, apps to support. What works in cessation? And when we're getting together these consortiums, where should we be focusing our energies?
I think there is a lot of, there's behavioral therapy and pharmacologic therapy, and there's a lot of data to support that, but there's also community-based programs. I think what happens with some programs, some initiatives, they're not studied as robustly as they should be to say that there's benefit. And I think we can already sense, tobacco doesn't get that recognition as other cardiac disease risk factors does. So then how much are all these efforts that are being put in later studied? We don't maybe have that 100% rate that afterwards we did this project and this was the most effective. We did this project and this was the most effective. So it's hard to sometimes say, because there's a lot of opportunity for community engagement, healthcare systems, physicians to work on this, but then you do want to direct somebody to something that is effective. I think, we have some things that are at a national level that I direct people to. We do have some pharmacologic therapy that has been studied, so I direct people to that in conjunction with their primary care physician, because some of those medications have implications for other issues that patients have. So always, from as how I would do it. I always coordinate with them, but a lot of these other things that we have, we would benefit from a lot more data to say, okay, we did this implementation, well, what was the success of that implementation, to then help people be directed to something, because of course we know it's very difficult to stop, so it would be great to send somebody to something that's as successful as possible from the get-go.
Thank
Can
you.
I just add to that? We know with all risk factors, really, that it is easier to manage them in an environment where the community is surrounding you, you're surrounded by a community that is supportive of that. A few years ago, I found out about a program in remote Australia which was dealing with obesity and trying to encourage weight loss. No individual weight loss was recorded. The loss of weight across the entire community was. And it was a really, really interestingly successful program because a community lost, 3,000 kilos in a month or something like this. And it was very, very effective. People will give up smoking if they live in a community which is helping them give up smoking. And there's a lot of different ways that can manifest, but I do think this is a community, not an individual problem.
Thinking about, so coming back to that example, I was thinking earlier, there's been a real drop-off in funding for organizations that are working in tobacco control and for NGOs and advocates to kind of keep pushing the messaging out there. And so how do organizations like the National Heart Foundation of Australia and even the Australian government, how can you support others in kind of keeping this movement and moment alive? Do you see a leadership role for Australia being one of the first, being one of the early movers in tobacco control? Do you see that there?
Look, as I said at the outset, I think we have to be very careful about learning from one country being implemented in another. Different environments, different landmass, different populations. I do think there is a part for Australia to play as a member of the group of nations which is trying to stop this happening. But I think it's very important that we don't try and translate Australian specific experiences to other countries. You touch on how people fund this kind of thing. I meet people who run heart foundations all around the world, and bizarrely, and it's a line I use a lot, I run a health charity. 60% of my revenue comes from dead people. Okay, I mean it is a very, very difficult thing and the British Heart Foundation is possibly even more dependent on bequests than we are. We have to make ourselves appealing to the living as well as people who are thinking about what they want to leave in their wills. And we've also got to move decades earlier in the impression that we make on people. Cardiovascular disease is traditionally something that we address when the train's left the station. You're allowed to get a heart health check in Australia at age 45. And if you go and have one and you have heart disease, forgive me, but it seems to me usually the doctor's telling you what you should have done 20 years ago. We are invisible to people in their 20s as yet. And we've really got to make...
I think so.
Okay. I actually just want to touch on your last statement that, so I focus in prevention. I mean, it is such a great field, such a great importance, but a lot of times people are like, oh, well, doesn't the primary care physician do all that? Well, then why is cardiovascular disease still the #1 cause of morbidity and mortality? We need to be very aggressive. We need to be very engaged to get this under control. I think it's not age 40, it's not age 50, it's age 20, it's age middle school, high school. Actually, like I was mentioning, our recent publication highlighting vulnerable populations, because of these flavorings and the marketing and whatnot, it's in middle school, it's in high school. So this is not something that age 40 and now I have to go see the cardiologist. It's not no, it's something that we need to work on, that we prevented right? We should, like, as I said, we need to try to prevent this from even becoming something that needs cessation. But really, I think that it's so much more earlier intervention to prevent this long-term problem later on is imperative.
Thank you. Any more questions from the group? If not, I'd like to just give you an opportunity to make a final reflection. So when thinking about tobacco control and where we get to in the next 2 to 5 years, what are your hopes and expectations in this area? So I'll start with you, David.
Okay, so my largest hope is that we can be absolutely brutal with vaping. I think that's the most important thing. I think there is a danger of a generation now of 15 to 20-year-olds coming up through with vaping having been normalized, who are going to be developing cardiovascular disease in the 2040s and the 2050s. None of us are really thinking that far in the distance, but we can see it. We don't have to do longitudinal studies on what vaping is going to look like after you've been doing it for 20 years. I think we have to hit vaping hard and ruthlessly, and almost forget everything else, because that to me is the biggest problem we face, because it's just going to sneak up on us, and we're going to have another generation of cardiovascular disease caused by nicotine products unless we knock that one over as hard as we possibly can.
Thank you. And Nori?
I would close with highlighting something that I'd already mentioned. I really hope that we can just prevent this, prevent people from using these products rather than working very hard. And yeah, we're ready to do it. We're engaged. We'll do it for cessation, but it's just so much easier to just prevent it from happening versus doing the discussion and whatnot. It's addictive. It's difficult for people to stop these things. So if we could just highlight preventing the use of these combustible, non-combustible electronic products, that would be the best.
Thank you. So we've heard two different perspectives today. The World Heart Federation has an expert group focused on this topic. It's the Nicotine, Tobacco, Alcohol and Drugs expert group. We've broadened the theme. It used to be just focused on tobacco, but recognizing a number of risk factors now. We'd really welcome your engagement with our work on this topic. So if you'd like to find out more and how you can be involved in that, please find me after this session at the booth. And all of that is to say, please join me in showing our appreciation for our wonderful panelists. And thank you for joining us today.